The anatomy of the duodenum. The duodenum extends from the pylorus to the duodenal flexure, where the transition to the small bowel proper is marked by the assumption of a mesentery. Is attached to the greater and lesser omentum. The remainder of the duodenum is retroperitoneal and as a result less mobile than the small intestine, except two parts, where the second part is crossed by transverse mesocolon and where the third part is crossed by the superior mesenteric vessel in the root of the mesentery. Here we have a picture of the second part where the transverse mesocolon mesentery is passing the third part. It is not covered by the peritoneum. The duodenum curves in a C shape around the head of pancreas. The first or superior, 2 centimeters in length at the level of L1 vertebra. The second ascending part, which is long 8 centimeters at the level of L2 vertebra. The third or horizontal 8 centimeters at the level ascending 4 centimeters ascending again to L2. Here we have a picture of the first part, second or descending, the transverse, third part, and the fourth part or the ascending part. On barium examination, the latter, which means the gallbladder, may indent the bulb. The common bile duct, the portal vein, and the gastroduodenal artery pass behind the first part of the duodenum and separated from the inferior vena cava. Inferiorly, it is in contact with the pancreatic head. Here we have a barium study which showed duodenal cava, which is the first part. The second part of duodenum has an opening halfway down on its posterior medial aspect for the pancreatic and common bile duct, which is called the duodenal papilla or ampulla of Vater. This is guarded by the sphincter of Oddi. An accessory pancreatic duct or Santorini duct, if present, opens 2 centimeters proximal to this, which means to the ampulla of Vater. The second part of duodenum is crossed by transverse mesocolon, as we mentioned before, anteriorly. And in this part, we don't half is supra and has the liver as anterior relation. It is lower half is infracolic and have right kidney and adrenal gland posteriorly and in contact with the pancreatic head medially. The Vater is guarded by the sphincter of Oddi, and here we have the accessory pancreatic duct of Santorini. The third part of the duodenum curves vena cava and aorta, include right psoas muscle, ureter, and gonadal vessels of posterior abdominal wall. Anteriorly, it is crossed by the root of mesentery. You can see it here. And the superior mesenteric vessels. The head of pancreas is in contact with the superior border. You can see.
يبدو النت ضعيفة، ده يقطع الصوت، احتمال يمك ضعيفة دكتور مروان.
The superior duodenum. The fourth تريد يعني أعيد من يا سلايد إذا قطع؟
لا يلا أوكي
استمر.
إيه تفضل.
نعم. The fourth part of duodenum pass upward and to the left side of the aorta, on the left psoas muscle here. It raises a peritoneal fold called ligament of Treitz. This is the ligament of Treitz. At the origin of the small bowel mesentery, the inferior mesenteric vessels raise another peritoneal fold lateral to the fourth part of the duodenum. Now we are going to talk about the arterial blood supply. The first 2.5 centimeters of duodenum is supplied by right gastric artery, right gastroepiploic artery, as is the adjoining the stomach. The superior pancreatico-duodenal artery, which is a branch of the gastroduodenal branch of the hepatic artery, supplies from beyond this midpoint along the second part, which passes behind the first part of the duodenum. The remainder of the duodenum is supplied by the inferior pancreatico-duodenal artery, which is the first branch of the superior mesenteric artery. At the midpoint of second part of the duodenum, therefore, there is a transition from supply by celiac trunk to supply by the superior mesenteric artery, representing the transition from the foregut to the midgut. So the foregut is formed by the first and second part of the duodenum. From the second to the fourth part is the midgut. Here we can see the anterior and posterior pancreatico-duodenal arteries, which has branched from the gastroduodenal artery, which came from the hepatic artery, common hepatic artery. And here we can see the anterior and posterior inferior pancreatico-duodenal artery, which has a branch of superior mesenteric artery, directly from superior mesenteric artery. Venous drainage. The first part of the duodenum drains to the pre-pyloric vein, or which is called vein of Mayo, which lies on the anterior surface of pylorus, and then to the portal vein. The remainder is drained by the veins that correspond to the arteries and which drain to the portal and superior mesenteric vein. يعني نفس تسميات من arteries بس راح تحولها veins. إذا anterior and posterior, superior pancreatico-duodenal vein, and inferior also. The lymphatic drainage. The pancreatico-duodenal node drain to the pyloric node, which drain to the celiac node. Now we came to talk about the radiological features. We have three methods, either by barium study, angiography, or ultrasound. The barium study. The duodenum is usually examined radiologically as a part of double contrast barium meal examination. How double contrast study is done? First, 100 to 150 ml of high density, low viscosity barium sulfate is used. Then antifoamic agent is then added to the suspension. Sodium bicarbonate or citric acid, given orally, or gas induced directly by Rayleigh tube. Injection of IV hypotonic agent like Buscopan is given when the barium enters the duodenum. Then the patient is rotated. This is a two picture. One represents the single duodenum and one of the double contrast. We use the double contrast study for the duodenum. There is another picture of the first, second, third, and fourth part of the duodenum by using the second barium meal study. There's another picture of the barium meal. We can see here on the first part, we have a duodenal ulcer, which is like a filling defect appear on the double contrast barium meal study. Now to the positions. We have some position we use to the examination of the duodenum. Because of the first part of the duodenum is passing posteriorly as well as superiorly, it is foreshortened in the AP view. So we use the right anterior oblique view. The patient is put in this way. On the right side is attached to the film or near the film, and the left side of the patient is raised from the table. This is the picture we have. Right anterior oblique. The projection with the rotation of the patient 40 to 70 degrees give the best image to the biliary canal and duodenal pulp. This is a special method to show the duodenal pulp, especially. Another method, which is the left posterior oblique position, lateral position for stomach and duodenum also. The third position is an AP projection, also for the antral of the stomach and the duodenum. The angiography. The angiographic assessment of duodenum will include two arteries, the celiac trunk and the superior mesenteric arteries. Both must be visualized. This is the celiac trunk. Here we can see number 1 is the catheter in the aorta, number 2 the tip, number 3 the splenic artery, 4 the left gastric artery, 5th the common hepatic artery, 6th the hepatic artery, and 7th left hepatic artery, 8th right hepatic artery, 9 right gastric artery. اللي يفيدنا من هذين كلهن اللي هو أكثر شيء اللي هو number 12 and number 13, which is the right gastroepiploic artery, and number 14 and number 15, which are the posterior superior pancreatic and the anterior superior pancreatic arteries. This is the superior mesenteric artery. Also, we have the catheter in the aorta, the superior mesenteric artery, the jejunal branches, the ileal branches, also the terminal superior mesenteric arteries, the ileocolic artery, and the right colic artery, the middle colic artery running superiorly, and the contrascal bladder. Here we can see it. Ultrasonography, which is the last method. The gas in the duodenum may hinder the visualization of other organs, particularly the common bile duct, which runs behind the first part. The duodenum may be identified adjacent to the head of the pancreas by the ultrasound. Here we have a picture, and here we can see an ulcer in the duodenal cap. Here's the duodenum, and there is an ulcer. We can see it here. Now we are going to talk about the small intestine, the second part of our lecture today. The small intestine begins where the intestine assumes a mesentery at the duodenal flexure and ends at the ileocecal junction. It varies in length from 3 to 10 meters, average 6 meters. The root of its mesentery extends from the left L2 to the right sacroiliac joint. In length, it is 50 centimeters in long. Small intestine is very mobile and lies in a mobile coil in the central abdomen. The proximal 2/5 is called jejunum and the distal mind. The circular mucosal fold, which is called the valvulae conventus or plicae semilunaris, are seen in duodenum and continued in the small intestine. They are less prominent distally and may be absent in distended view on barium study. Barium study between duodenum and ileum. On duodenum, the diameter is wider than the ileum. The wall thickness is thicker in duodenum. The position, we can see it on the left upper abdomen, while the ileum in the right lower abdomen. The valvulae conventus in the ileum. The pia patch is fewer and bigger than the ileum. The arterial arcade, which is 1 or 2 with fewer long arterial blood supply of the small intestine. The entire small intestine is supplied by the superior mesenteric artery, raised from the aorta at the level of L1. Jejunal and ileal branches arises from the left of the main trunk, these but number up to 5 in the distal ileum. Basarecta are end arteries that enter the intestinal wall. Here we can see it. This is the jejunal, and this is the ileal. This is the basarecta, which is an end arteries enter the small intestine. Both are branches of the superior mesenteric artery. the venous drainage of the small intestine, which in turn drain to the portal vein, superior mesentery to the portal vein. Lymphatic drainage. Lymphoid follicles found in the mucous membrane throughout the intestinal tract, the small intestine. In the distal ileum, they become aggregated together into patch called Bayer patch. They are oval in shape, found on the superior mesenteric group of the pre-aortic articulum that project from the anterior mesenteric border of the lower ileum represent the persistent intestinal end of the vitellino-intestinal duct, which connect the yolk sac to the primitive digestive tube in the early fetal life. It is found about 2%. MECKEL'S diverticulum is said to be 2 inches or 5 centimeters long and situated about 2 feet or 6.5 meters. Here we have a picture of the MECKEL'S diverticulum on CT, axial CT. Another picture on the axial CT. The radiological features of the small intestine. We have 4 methods for visualizing the small intestine: the plain film, the barium study, the CT scans, and the angiography. We came to the plain film. The gas and the fluid level are often visible in normal loops of the small intestine, up to 5 fluid levels in loops of 2.5 centimeter diameter or smaller, or 2 loops wider than this, may be seen on the normal radiograph. Jejunal loops are distinguished from the ileal loops by their with the former in the left upper abdomen, whereas the ileal loops tend to be in the lower abdomen and to the right iliac fossa. In the radiograph of intestinal obstruction, the central position of dilated small bowel loops help to distinguish them from loops. Other identifying feature of the small intestinal loops include the circular valvulae conventus, distinct from the incomplete septa formed by the colonic hostra for the colon. Here we have a signs of a small bowel obstruction. Always we will have, not always, we have a dilated loops of the small bowel proximal to the obstruction. Second, we have predominantly centered dilated loops, 3 instances of dilatation more than 2.5 to 3 centimeter. Reference required valvulae conventus are visible. 4, we have a gas fluid level if the study is in on direct position, especially suspicious if we have more than 2.5 centimeter in width in the same loop of small bowel, but at different heights, more than 2 centimeter in difference in height. However, this is not typical. Obstruction, which may be high-grade mechanical obstruction, may also present with the following feature: gasless abdomen, string of beads sign, noting a small bowel obstruction. We can see here the air fluid levels. Here distended small intestine, which is centrally, and we can see the valvulae conventus and stack of coins. This is a string of beads, which is a typical sign of high mechanical obstruction. Now we came to the barium studies of the small intestine. For the small intestine, we use 2 methods: either barium follow-through examination or the small bowel enema or enteroclasis. The first barium follow-through examination, the barium is taken orally and imaged as it passes through the cecum. The small bowel enema or enteroclasis, a tube is passed to the duodenal flexure and the barium is passed directly into the small intestine. The normal upper limits of diameter are higher for the distended bowel than for lax state. Thus, diameter up to 4 centimeter in the jejunum and up to 3 centimeter in ileum are normal. يعني اكو اصلا صار بها expansion يعني. Normal valvuli conventus may be up to 2 mm in thick in jejunum and 1 mm thick in the small bowel animal. The valvuli conventus may be absent in the ileum when it is distended, giving it a featureless appearance. Here we have a picture. Here we can see the circulation. We can see a collapsed transverse colon. We can see the duodenal bulb or cap. This is the stomach. This is the splenic flexure. There's the duodenal junction, and this is the jejunum, and this is the ileum. This is a barium follow-through. So it is showing the stomach, duodenum, and the small intestine, and even the colon. Another picture. Follow-through. This is the jejunum, and this is the ileum. Also follow through the erect position. We can see the duodenal cap here. The second, third, fourth part of the duodenum. This is the jejunum, and this is the ileum. This is about the time. So when we give a barium meal, after half hour, we can find it still in the stomach, and it will start to enter the duodenum and the small intestine. After 1 hour, it will appear to accumulate in the jejunum. After 2 hours, it will be accumulated in the duodenum, the ileum and jejunum, and will also enter the colon. Now we'll come to the CT scan. Oral contrast distinguish normal loops of the small intestine from the abdominal masses. Loops of the small intestine fill most of the middle abdomen and upper pelvis. When adequately filled with oral contrast, the thin wall of normal jejunum is almost imperceptible. Fine, transversely thickened area due to the valvuli conventus may be seen. These are seldom seen in ileum. The mesentery and its vessel and fat may easily seen on CT. Lymph nodes are frequently visible in the mesentery. يعني تقريبا CT will show everything in the small intestine. This an axial CT scan. We can see here the jejunum. Also the jejunum. This is the second part of jejunum. This is a sagittal CT, one directional CT scan.
هذا كورونا مو سجتر. غلطانين. لذلك
نعم.
نقول لكم دائما مو كل اللي كتبوه هذه بالكتب بالهاي هو صحيح. هذا كورونا.
عفوا استاذ مو from side to side sagittal يعتبر؟
لا كورونا هذا.
يعني هاي liver all the small intestine. واضح. يعني هسه كورونا هذا استاذ؟
طبعا كورونا. وين السباين؟ وين السباين؟
ما
البلفيس،
طالع.
الإيليك بونز، الليفر مبين، البوث لانجز. هذا كورونا.
واضح استاذ. غير بالمحاضرة ان شاء الله.
ناقلة غير ناقلة؟
نعم ناقلة، بس من اكثر مصدر شفت انه مكتوب ساجيتال فخلاص يتغيرها ان شاء الله.
لا
ان شاء الله.
بس يعني اكو اخطاء دورات بالكتب وبالهذه.
نعم.
انتبهوا لها انتم لا شو اسمه. بس هذا كورونا.
نعم واضح استاذ.
اوكي تفضل.
واضح. The small bowel action on CT. Here we have intravenous contrast only used. We can see the decompressed small bowel distal to the point of the obstruction. This is the point of obstruction. We can see dilated bowel more than 2.5 centimeters in diameter. This is a dilated bowel with a bright enhancement of a viable bowel wall with IV contrast. نعطينا IV contrast وياه. The angiography. The selective injection of the superior mesenteric artery demonstrates the jejunal and ileal branch of the arterial arcade. The mesenteric vessels can also be readily identified on a contrast-enhanced CT and angiographic MR sequences. This is superior mesenteric. We can see to number 3 and number 4, the jejunal and ileal branch of the superior mesenteric artery. Now we came to the quiz. نبدأ استاذ؟
يلا ما عندنا
نعم.
اكو احد عنده سؤال شيء قبل ما نبدي ارجع برا عليه.
نعم.
اكو احد عنده سؤال قبل ما نبدي الكويز؟ ماكو. يلا خلينا نبدي الكويز.
واضح استاذ.
هدى رعد دكتورة هدى ويانا. إيلاف.
السلام عليكم دكتور.
عليكم السلام.
رقم 1
نمبر 1
هذه الكاثيتر بالايورت.
excellent. الكاثيتر of the angio. أميد. نمبر 2.
نعم أستاذ. Number 2, this is the superior mesenteric artery.
The superior mesenteric artery. Excellent. تبين نمبر 3 هاي البرانشز شو يسمونها؟
Jejunal branches.
Jejunal branches. Excellent. حسين عبد الكريم.
أستاذ الإليال برانش of superior mesenteric artery.
Ilial branches of the superior mesenteric. نروح على دكتور عماد.
أهلا أستاذ، صباح الخير.
صباح الخيرات.
terminal arteries هذه أو terminal supply.
Number 5 terminal supply of the mesenteric artery. Number 6 دكتور عزام.
نعم أستاذ، صباح الخير.
صباح الخير.
أستاذ هذا إيديوكوليك أرتري.
إيديوكوليك أرتري. سارة عباس رقم 8.
نعم أستاذ. رقم 8 هذا middle colic artery رقم 8.
middle colic artery. خلصا مو؟ أي. أستاذ محمد.
وياك استاذ رعد عيني.
يلا هذا
احمد ماجد. احمد ماجد موجود؟
عفوا أستاذ، أحمد كول خابرني الصبح بلغني هنا.
ماشي. تمارة عبد الجبار.
نعم أستاذ. Number 1 circulation of the small bowel.
circulation of the small bowel. رقم 2 حسين عبد الكريم.
نعم أستاذ.
على 2
مروان انت اشر لهم على شو اسمه لانه الارقام صغار.
نعم.
ابني مروان اشر له.
صح.
نعم أستاذ. هذا كولابس يصير بال transverse colon أو بالكولون.
ربع رقم 3.
نعم أستاذ. 3 duodenal bulb.
رقم 4 رغد سعدون.
نعم أستاذ. الستومك.
5 زاهد علي.
نعم دكتور. سبلينيك فليكتشر دكتور.
شلون؟
سبلينيك فليكتشر.
نعم. ما أعرف، هاي يمكن بها خطأ. مو سبلينيك فليكشر، هذا سمول باور. هذا
هو الكونتينيويشن استاذ محمد مال السيركيوليشن مال الكولون اذا تتبعه هو دا يصعد للليفت ابر كوادرنت، فهو سبلينيك فليكشر.
هذا عاد مو التأشيرة على الباريوم، نخليها على الباريوم.
اي هو هذا السبلينيك من تتبع رقم 2 ورقم شو اسمه رقم 2 كان كولابس ترانسفيرس كولون.
دكتور
تمام.
بس سؤال، هو ليش هيك عالي يعني؟
لا هو يصعد هو من اسمه فلكشر يوصل للسبلين، والهيباتيك فلكشر هم يصير انه اعلى شيء
هو
بالبول.
بالعاده اعلى من الهيباتيك فلكشر، بس شو هنا بتخيله
اي
كلش عالي.
شويه اعلى. اي مو هذا الدايفرجنت مالت الاكس راي، تعرفين هو سنترالي البيم يخلوه سنترالي، فطبعا تبين بنهايه الفيلم يعني. بس هو سبلينيك فلكتشر بالضبط، لانه حتى الدايميتر مالته وما بي يعني احنا نعرف عاده بالليفت ابر كوادرنت الجوجينال لوبس اللي بيها الفيثري ابيرنس اللي موجوده هي اذا تلاحظوها، وتقل هاي الفالفولي كونفنتس وهذه باتجاه الايليوم، فهذا كولون. اوكي.
رقم 6 زهراء عبد الحسين.
نعم أستاذ، هذا الدودنا جوجينال جانكشن.
زين. رقم 7 سماء عطية.
نعم أستاذ. This is the jejunum.
نعم جوجينم.
This is jejunum.
رقم 8 شيماء مجيد.
نعم أستاذ، هذه الإليوم.
عندك بعد شيء خلصا؟
لا